we're going to discuss the next system on cardiothoracic surgery. So one of the small chapters, but we used to get few questions from this chapter, so let us have an idea about all those important points. So nowadays, in exam, we are seeing the national board examiners are going more concentration towards specialty topics. Otherwise, in those days, like 2 years back and all, the number of questions in specialty topics will be very less. So nowadays, we are seeing so many questions from specialty topics. So last year, around 15 questions came from the specialty alone. That is the reason I'm focusing more depth of all the specialty topics this year. So please remember the points I'm going to tell now in cardiothoracic surgery. The first heading under this is cardiac surgery. We're going to discuss about cardiac surgery. So when we're going to discuss about cardiac surgery, first of all, you should know what is this machine shown here. What is this machine? This is an expected image based question. This is cardiopulmonary bypass machine. Okay, this is cardiopulmonary bypass machine shown here. So there is an enormous discussion about this machine and the principle in billion. So when you start cardiothoracic surgery, the initial discussion is on this topic alone about the cardiopulmonary bypass. So what I'm going to do in a cardiopulmonary bypass, first I will do sternotomy. So this is one of the important things. When we are doing a cardiac surgery, we cannot go and do directly. The heart will be pumping, the blood will come out. So to prevent that, when we are doing a cardiac surgery, we have to connect the patient to a machine known as cardiopulmonary machine. We have to do sternotomy. We have to expose the heart, and after exposing, I have to do arterial cannulation. Arterial cannulation. Arterial cannulation is done at ascending aorta. Is done at ascending aorta level. So I'm going to cannulate at ascending aorta level like this. For example, let me show you simple method I'm drawing here. So this is a ascending aorta going up like this. So what I will do is I will clamp it here and I will connect it to a cannula like this. This is a CBCABG machine. This is going to the machine. This is going to machine. So hereafter the arterial blood will come from the machine. Okay, come from the machine. Then I have to do venous cannulation. Venous cannulation. So where is the vein which is oxygenated blood from the lungs is going to is now through the right atrium. Here I will make a purse string and I will take a cannulation. So this is connected to the machine. This is also connected to the machine. So venous cannulation is via purse string in the right atrium. So now you can see the entire blood is not entering the heart. So now the blood which is the function which the heart is going to do, the function of heart is now going to be done by a machine sitting here. That is the machine shown here. So this machine, what are the things it will do? What are the functions by this machine? This machine will oxygenate. Please remember, very interesting point. Oxygenate the blood, remove particles, maintains temperature, maintains the needed temperature, and maintains circulation all over your body except heart. It maintains circulation in your body except heart. So please don't forget the patient will have oxygenation, removal of particles, temperature maintenance, circulation, everything is done by the machine. By cannulating ascending aorta, and by cannulating into the right atrium, we are doing this machine. So the machine is hereafter going to take care. Machine is going to take care. Take care of your entire circulation, like brain circulation, GI circulation, everything is going to be taken care of this machine. Except one area which will not be taken care of the machine is myocardium. Myocardium is not taken care by this machine. So myocardium receives its blood supply from the left coronary artery and right coronary artery. So that is now blocked. We are clamping here. No, the right coronary artery and left coronary artery are not receiving the blood. Therefore, the myocardium will not receive the blood. So how can I now prevent the myocardial damage? Is an expected MCQ. To prevent myocardial damage, what I will do? To prevent myocardial damage, what should I do? So to prevent myocardial damage from Bayesian law, everything I'm telling in this specialty chapter is only from Bayesian law. To prevent this myocardial damage, I should infuse cardioplegic solution. Cardioplegic solution is infused into the myocardium, and usually it is potassium containing fluid. When you infuse potassium containing fluid, the heart will stop at diastole. That will be diastolic arrest. And therefore, when it stops at diastole, the myocardial survival is increased. So therefore, cardioplegic solution is one method. One method is by cardioplegic solution. And number two, we can do intermittent cross clamping. Intermittent cross clamping means we allow the blood to flow into the coronary arteries by intermittent cross clamping method. By a cross clamping method, we allow the blood to flow into the coronary arteries. And when this is happening, usually the heart develops ventricular fibrillation. The heart will develop ventricular fibrillation. So intermittent cross clamping with the induced ventricular fibrillation, the myocardium can be protected. And especially in pediatric patients, we have to do total circulatory arrest. Total circulatory arrest is done in pediatric cases. So total circulatory arrest, the heart myocardium can withstand ischemia for about 15 to 20 minutes. So the total circulatory arrest, the myocardium can withstand the ischemia for 15 to 20 minutes. It's especially done in pediatric cases. To prevent myocardial damage, what are the things you do is we infuse cardioplegic solution, intermittent cross clamping, or we can go for a total circulatory arrest with which we can operate the myocardium for 15 to 20 minutes. It is usually done for pediatric cardiac surgery, not for adults. So these are the points you should not forget in cardiopulmonary bypass. As cardiopulmonary bypass working, what are the complications you can develop according to Bayesian law? Complications are bleeding. Patients can go for bleeding disorders. Patients can go for infection. Patient can develop air embolism. And now the patient can develop specific organ, GIT, mesenteric ischemia. Specific organs may lose their blood supply and develop mesenteric ischemia, myocardial ischemia, neurological dysfunction, so CNS dysfunction, pancreatitis. All these are due to ischemia going to severe organ, vascular injury. So mesenteric ischemia, myocardial ischemia, neurological dysfunction, pancreatitis, vascular injury. Sometimes the patient may even develop multi-organ dysfunction syndrome, MODS. All these things can happen in a patient who is on cardiopulmonary bypass machine. Okay, to avoid this cardiopulmonary bypass machine, there are new devices are coming. Without doing a bypass, we can use certain devices. I will show you the image of the device. I am showing the images, so in which we can directly operate by cross clamping the ostia of the coronaries. I'll show you that when I'm discussing. So in this chapter, I'm going to discuss only one important topic, that is acute coronary ischemia or cases of myocardial infarction patients. Coronary occlusion, I'm going to discuss in this. Coronary ischemia, acute coronary ischemia. To understand this, you should understand the important anatomy I'm drawing now. So this is the picture of heart, just I'm drawing in a blind way, and this is a aorta. And from aorta, we have two important arteries coming. What are they? That is left coronary artery, left anterior descending artery. This is left anterior descending artery. Left anterior descending artery, and this is left circumflex artery. Okay, circumflex artery. So this actually the main artery is known as left coronary artery. So please remember, from the left coronary artery, two branches are coming. One is left anterior descending artery, another is circumflex artery. Can you tell me where is the left anterior descending artery running on from the picture? Where is the left anterior descending artery running here? It is running on the anterior interventricular septum. Anterior interventricular septum. It's running on the anterior interventricular septum. So therefore, it is also known as anterior interventricular artery. Left anterior descending artery is also known as anterior interventricular artery. So circumflex iliac artery is running on the atrioventricular septum. It is running on the atrioventricular septum like this. So the main artery is left anterior descending artery, which is giving left coronary artery, which is giving two branches, left anterior descending and circumflex. The next branch is right coronary artery. So the right coronary artery. So right coronary artery, it continues on the posterior side, on the posterior interventricular septum as posterior descending artery. So posterior descending artery is a branch from right coronary artery in around 90% of the patients. But in 10% of the patient, posterior descending artery can come from left coronary artery itself. So therefore, if you see the left coronary artery is the main vessel. Left coronary artery is the main vessel for the myocardium. And left coronary artery, please don't forget, is giving branches left anterior descending, circumflex, and sometimes it can also give posterior descending artery also. So the three vessels we are discussing. What is it? The three vessels are left anterior descending, circumflex, and posterior descending artery. These are the three vessels we are discussing. When we are discussing, the people will use to tell my three vessel block, two vessel block, one vessel. Like that, the three vessel. This means circumflex artery, left anterior descending artery, posterior descending artery. Among these three, most commonly diseased artery is what? Most commonly diseased artery, most commonly bypassed artery is what? It is left anterior descending artery. Please don't forget. Left anterior descending artery is the most commonly diseased artery. So when a patient comes to you with a coronary ischemia, a coronary occlusion, the investigation of choice is selective angiography. We have to cannulate to the radial artery, go to the coronary ostia, develop aorta, and push the contrast. So selective coronary angiography is done. Selective coronary angiography will show you clear-cut anatomy of the vessels, which are the vessels, etc. You can find out. And based on this, when will you do coronary artery bypass grafting? Indications of CABG from William Love. So selective coronary artery angiography you are doing. When will you do CABG? Means number one, when there is more than 50% stenosis of left coronary artery, main artery, 50% stenosis of left coronary artery. Main artery is more than 50% stenosed. Number two, more than 70% stenosis of which artery? Left anterior descending, also known as anterior interventricular artery. Anterior interventricular artery or left anterior descending artery, more than 70% occlusion. Okay, all the three arteries are occluded, or three vessel disease, or triple vessel disease. We have to do surgery. And number four, poor ventricular function. Because of MI, the patient's ventricle is not functioning properly now. Poor ventricular function. The ventricle is not functioning properly. So when will you do surgery? Coronary artery bypass grafting from Bailey and Lewis. More than 50% stenosis of left main artery, more than 70% stenosis of left anterior descending artery, or if there is a three vessel disease or poor ventricular function. In all these cases, I have to do coronary artery bypass grafting. Please don't forget this. Okay. So then what are the other problems apart from stenosis of the vessels? Other problems we can get are chronic stable angina. Chronic stable angina patients. The patient is having angina for long period and it is stable. These patients are simply treated by newer method, percutaneous transluminal coronary angioplasty. Percutaneous go inside, go into the narrowing area and put a stent. Percutaneous transluminal coronary angioplasty is done for chronic stable angina, better than CABG. Nowadays people are not going for CABG. Better than that, we are doing percutaneous transluminal coronary angioplasty. And patients who are having acute coronary syndrome, like unstable angina patients. Please remember, unstable angina patients. The patient is having an unstable angina. Unstable angina usually becomes asymptomatic. They become asymptomatic within 48 hours just with the anti-anginal drugs. Become asymptomatic with help of anti-anginal drugs is enough. But if they are having recurrent unstable angina, we have to go for, if it is recurrent, we have to go for PTCA, percutaneous transluminal coronary angioplasty, or we have to do thrombolysis. The patient is having recurrent unstable angina, we can do percutaneous transluminal angioplasty or thrombolytics. In these cases, if you want to do surgery, we should do surgery in these patients. CABG can be done after 6 weeks. These are all direct lines from Bailey and Love. So I want to remember this is all Bailey and Love points. Now, chronic stable angina, PTCA. Unstable angina patients, asymptomatic patients, we can give anti-anginal drugs. That's enough. They become asymptomatic within some time. If it is recurrent, we should do percutaneous transluminal angioplasty. If you are planning for surgery, please do surgery after 6 weeks of this problem is over. Okay. And what are the other indications of surgery in a MI? Other indications. So see, you can note very well, I'm not discussing the various basic things of diagnosis of MI like troponin, all those things I'm not discussing. I'm discussing only the surgical aspects, expecting you to read all those things from medicine. Okay. So other indications are the myocyte can go for necrosis. Myocyte necrosis. When the myocyte necrosis, there will be ventricular septal defect which will happen in the heart. The myocyte necrosis, there will be ventricular septal defect. The patient presents in 3 to 7 days with a classical clinical feature of pulmonary edema. Patient may have pulmonary edema, pansystolic murmur, plus hypotension will be present. So these patients all will need immediate surgery. We have to make a patch closure is needed. So the myocyte has gone for necrosis and there is a gap in the ventricular septal defect, myocyte necrosis. Then comes papillary muscle necrosis. Papillary muscles are the muscles which form the valves. When the papillary muscle goes for necrosis, there will be major problem, that is mitral valve regurgitation, MR will be happening. So these patients, mitral regurgitation patients also will come to you with a pulmonary edema. They also will come to you with a pulmonary edema and pansystolic murmur. So they also will come to you with a pulmonary edema and pansystolic murmur. The treatment is mitral valve replacement is the treatment for these cases. So what other problem can happen? Ventricular aneurysm can happen because of the partial necrosis. Ventricular false aneurysm can happen. Necrosis of the ventricular wall. The wall of the ventricle will bulge out like this. That will result in a ventricular aneurysm. So we have to repair it immediately, and the repair is undertaken with the help of CABG machine. Coronary artery bypass machine. Bypass machine is used here. So repair after connecting the heart to bypass machine. Okay, please remember ventricular aneurysm, papillary muscle necrosis, myocyte necrosis. Myocyte necrosis associated with VSD, papillary muscle necrosis associated with mitral valve regurgitation. Ventricular aneurysm will need replacement or repair with the help of bypass machine guidance. Okay, so now what are the things I'm going to do mainly in bypass? So bypass operations of the stenotic vessels, I'm going to do bypass with the help of usually long saphenous vein or usually with the help of lima. These are the two vessels they commonly use. So anybody, any cardiac if you see, they commonly use long saphenous vein or left internal mammary artery. Left internal mammary artery is commonly used two vessels. So long saphenous vein is the most commonly used vein. Most commonly used vein is long saphenous vein. It has a life expectancy, 10-year patency is only 60%. It can be useful for 10 years, only 60%. What are other veins we can use? Other veins, we can use short saphenous vein, we can use cephalic vein also. But whatever it may be, when you use vein, the 10-year patency is 60% only. That is why we mostly use lima or the arteries for the left coronary artery and left anterior descending artery bypasses. We use only arteries. Left coronary and left anterior descending artery bypass. We should use lima because the 10-year patency is around 90%. They have 10-year patency of 90%. When I use the left internal mammary artery, the major problem is wound infection, especially in diabetic patients. May develop wound infection. So what are the other arteries we can use? Other arteries. So lima is also known as internal thoracic artery. Left internal mammary artery is also known as left internal thoracic artery. So what are the other arteries used? Rima, right internal mammary artery, or we can use radial artery. Internal mammary artery is not available, we should use radial artery. Please remember, we will use radial artery. So before using the radial artery, we should do this test. Compress both sides tightly and look for the hands becoming white, and take one, the color will change into pink. And take, similarly compress and take other, the color becomes pink. So this white color changing into pink on this test is known as Allen test. I hope you all know the test. Allen test is done before taking radial artery. So Allen test is to look for the patency of the palmar arch. Patency of the palmar arch is present, we can remove the radial artery. Palmar artery will supply the palm. Okay, that is the concept. So radial artery can be used. So especially the point here is the left anterior descending artery or left coronary artery are mainly bypassed with the help of these vessels like lima or rima or radial artery because they have 10-year life expectancy, like the 10-year patency. So what are the complications of this bypass operation? The complications of these bypass operations are bleeding, arrhythmias. So the most common arrhythmia is sinus tachycardia. Neurological dysfunction, poor cardiac output, and even patients can die. Mortality is also seen. Mortality is 2 to 3% in the recent era. The mortality in this bypass operation is 2 to 3%. Bleeding, arrhythmia, neurological dysfunction, poor cardiac output, mortality, and wound infection are the various complications of CABG. The CABG operation usually starts with the retrieval of long saphenous vein. We usually start the operation by starting with the retrieval of veins. The vascular surgeon will come and retrieve the vein. The cardiac surgeons will start preparing the bed. Okay. And prognosis after this operation is, so prognosis is 95% will survive at 1 year. Okay, 95% at 1 year, 90% at 5 years, and 75% survival at 10 years after this operation. So prognosis of this operation, after CABG operation, you could see 95% living at 1 year, 90% at 5 years, and 75% are living at 10 years after surgery. So this is about the bypass operations. Okay, so bypass operation. I told you, when I'm doing this coronary artery bypass grafting, I should need bypass machine. This is what I told you. I will need a bypass machine. But instead of bypass machine, there is one more method available: off pump. Off pump coronary artery surgery is a surgery which needs no bypass machine. There is a special device available. I will show you the device, that is Octopus device. We use one Octopus type device which will cross clamp the aorta level so that the blood will be flowing on one side, except the myocardial blood. We can go and slowly repair that by means of this Octopus device. It's an off-pump coronary artery surgery. Off-pump coronary artery surgery is an upcoming operation everywhere. Okay. And one more operation we do in heart surgeries is valve replacement. The other operation we do is valve replacement. So when we are discussing about valves, we should know there are two types of valves available. What are the valves? One is mechanical valve. Another is biological valve. So mechanical valve is manufactured in the company and it can be used at any age, any size is available because it is manufactured in the company. The major advantage of mechanical valves is it has long durability. It can be available for even 15 to 20 years. Long durability, it will be working for 15 to 20 years. But the problem with the mechanical valve, the disadvantage is it is made up of metal. So what will happen? As every time the blood is passing inside, it will rupture the RBC. As it ruptures the RBC, the thrombotic materials are released out, and therefore it is more thrombogenic. And lifelong anticoagulation needed. This is a major problem with mechanical valves. Lifelong anticoagulant should be given for these patients. So it is thrombogenic, it can rupture the RBC, so we need lifelong anticoagulation. Whereas biological valves can be homograft or autograft, say allograft, autograft, or it can be heterograft. Hetero is nothing but xeno. So allograft is taken from cadaveric graft, from cadavers. Autograft is from same individual. Some valves are less important. Mitral valve is more important than a pulmonary valve. Like that same valves can be used, same patient's valves. So instead of what we do is remove the tricuspid valve, put it in the mitral valve. Like that same patient we use the same graft, autograft. Xenograft is taken from animals like porcine, pig. So in practice, the most commonly available biological valve is porcine valve. And the major advantage of this biological valve is it is a thin valve. It is a thin, fragile valve, so turbulence is less. So no anticoagulant needed. No anticoagulant needed. So disadvantage, what is the disadvantage of this? The disadvantage is less life expectancy. Unlike the mechanical valves which can be used for 15 to 20 years, this can be used for only for 10 years, maximum 15 years. Less life expectancy is there in this valves. Okay, especially the porcine graft will have life expectancy less than 15 years only. So therefore, this is a less life expectancy problem. And what are the complications of using a valve? The problems with this valves are, the most common complication is thrombus formation. Thrombus formation is the most common complication. That is why we give them lifelong anticoagulants, and it is more common in mechanical valves, and it is more common in mitral valve. And the valve can also get valve leak. And major problem is the valve can always produce prosthetic valve endocarditis. Lifelong there is a risk of prosthetic valve endocarditis. So they have a risk of lifelong endocarditis. Okay, tell me what is the most common organism causing this prosthetic valve endocarditis? It is staph epidermidis. So the prosthetic valve endocarditis is mostly due to staph epidermidis. The risk is lifelong, and the mortality with this complication is 50% mortality. Staphylococcus epidermidis can cause 50%, 0.50% mortality seen because of prosthetic valve endocarditis. So this is about the valve related problem, and the last topic in this tumors is about tumors. In heart is about tumors. So the most common cardiac tumor is metastasis to heart. So please remember, metastasis to myocardium is the most common tumor. The most common primary tumor is atrial myxoma. Please don't forget, the most common primary tumor is atrial myxoma is the most common primary tumor. So what is the most common organ causing metastasis? This metastasis is commonly from lung cancer. Please remember, it is usually from lung cancer. And there is another question, which primary has highest propensity or highest rate of metastasis to heart? Highest propensity of mets to heart is mainly from malignant melanoma. So please don't forget, the most common metastasis is from lungs. Who will have highest mortality percentage is melanoma. Most common tumor is atrial myxoma. Most common primary tumor is atrial myxoma. Mets is from lung, and highest propensity to mets to heart is from malignant melanoma. I want you to know a few points about atrial myxoma in this chapter. Atrial myxoma is a very important topic in this chapter. It is there in very low, discussed in detail. This is the most common cardiac tumor. It is common in 3rd to 6th decade among females. It is common in 3rd to 6th decade among females, and it can be sporadic or familial. Sporadic or familial types are there. Familial types are associated with the Cornice complex can have familial atrial myxoma. An interesting point is sporadic cases will form most commonly in left atrium. It is commonly found in left atrium, whereas familial is most commonly found in ventricle. Myxoma is most common in ventricles in familial form. Left atrium in sporadic form. In sporadic form, it is usually, please remember, sporadic form is usually common in the left atrium and it is usually solitary. Familial form is common in ventricle and it is usually multiple. Please don't forget this point. This is there from Savitsan, not from William. Okay, it is there from Savitsan. Atrial myxoma is common in 3rd to 6th decade among females. Sporadic form is common in the left atrium. Familial form is common in ventricle and multiple. Okay, what is the clinical presentation of these cases? Especially sporadic form presents you with a classical feature of mitral stenosis or mitral regurgitation-like features. The most common clinical feature of atrial myxoma is mitral stenosis or mitral regurgitation. So ventricular forms usually present with obstructive feature. They present as obstructive features. And when you examine an auscultate, you can hear the classical tumor plop sound on auscultation. You can hear the tumor plop sound, especially in the mid diastole. In the mid diastole, you can hear a tumor plop sound. Tumor plop sound is heard on examination. The major complication or the major issue is when the atrial myxoma disconnects and becomes an emboli. Emboli-like manifestation can happen if it disconnects. Please remember this. If it is disconnected, emboli-like manifestation can happen. Investigation for this case is, it is by means of 2D echo or by means of transesophageal echo is done, and the treatment is always surgical excision. So the treatment is surgical excision of atrial myxoma. So please remember, atrial myxoma is common in left atrium, producing symptoms similar to MS or MR. So please don't forget, this is a cardiopulmonary bypass machine, and this picture is taken from William Love, how the circuit is working. So the circuit is going to do oxygenation, removal of foreign bodies, maintaining temperature. Everything is done by this circuit which is here. This is a cardiopulmonary bypass machine. Okay, so once machine is connected, cardiolytic solution is infused into coronary artery. It is potassium-containing fluid that arrests the heart and diastole and hence commonly used. So to prevent coronary myocardium damage, we will use cardiolytic solution. Please don't forget it. So the various complications of cardiopulmonary bypass I told you, and this is a selective angiography showing you there is a stenosis at the main left coronary artery. You can see left coronary artery, there is stenosis. So how will it look like normally? Normal appearance is shown here. So this is a normal coronary angiography. You can see all the vessels going for, all the vessels are clearly shown in this. Okay. So indications of CABG: more than 50% stenosis. Okay, more than 50% stenosis of the left main artery. More than 70% stenosis of the left anterior interventricular artery. 3 vessel disease, poor ventricular function. All these patients we should do CABG. Okay. Now this points we have discussed, and you can see the valves. This is how you do bypass. In this picture, you can see from the left subclavian artery, the lima is coming and supplying the left anterior descending artery. This is how you do. For a left anterior descending artery, lima is going to bring blood from the left subclavian artery like this. And other vessels are usually done with the help of saphenous vein. So venous graft is used for others, but for main vessel we use lima. So this is an off-pump coronary artery surgery. I told you, it looks like an octopus-like device. In this, we will do a cross-clamping. In this picture, you see this space, we will do a cross-clamping like this. With the help of cross-clamping, without bypass, we can do surgery. Without bypass, major bypass, we can do this surgery by means of this off-pump coronary artery surgery. So these are the two valves. You can see the typical mechanical valve, which will have long durability. This is a biological valve taken from porcine pig, so it is having less life expectancy. But the major problem with this is, you can see how the blades are continuously ruptured RBC. Therefore, we should use this very carefully. This can cause coagulopathy. Therefore, we should use anticoagulants lifelong. So the various valves, we have discussed the tumors. Please don't forget the tumors. So this is the first chapter, cardiac surgery. Very small topics. Please don't forget all these topics. Okay? Thank you.